Scapholunate dissociation. The anatomy of this injury includes the scaphoid and lunate, as well as the scapholunate interosseous ligament. The pathology of this injury is separation of the lunate and scaphoid. The scaphoid will experience palmar flexion, whereas the lunate will experience dorsiflexion, creating a gap between the two bones, which is displayed to the right. The mechanism of injury is falling on an outstretched hand or fouche, as well as a stress load on an extended wrist with ulnar deviation. Signs and symptoms include pain on the radial side, pain in anatomical snuff box, ecchymosis, edema, a feeling or hearing of a snapping sensation, a weak grip, clicking and or catching of the wrist. Differential diagnosis includes scaphoid fracture, radial styloid fracture, scaphoid impaction syndrome, dorsal ganglion cyst, ulnar translocation, and perilunate dislocation. The special tests for this injury are the Watson's test and Murphy's sign. For Watson's test, the patient will go ahead and position their arm as if they were about to arm wrestle someone, and the examiner will place one hand, specifically the thumb, over the scaphoid. The examiner will then take their other hand and passively move the patient's hand into ulnar deviation with slight extension. From that position, the examiner will move the patient's hand into radial deviation with slight flexion. The test is considered positive if there is a thunk sensation underneath this examiner's thumb. Murphy's sign is a lunate dislocation special test. However, the two go hand in hand together. To examine this particular test, the patient will have a closed fist and the examiner will observe the third metacarpal. The test is considered positive if the second, third, and fourth metacarpal are in alignment. However, as seen in the picture, you can see that the third metacarpal is slightly raised compared to the second and the fourth. Mulligan Technique will be manipulation of the provocative movement that the patient is complaining of, leading to an anterior-posterior glide or medial-lateral glide. Predisposing factors include anatomical structure, elderly patients, previous fractures of the wrist, and previous subluxations or dislocations of the wrist. This injury can be managed and treated using rest, immobilization, using a splinter cast, police, NSAIDs, specifically, for example, ibuprofen, an X-ray to determine the severity of the injury, an MRI or CAT scan to determine if there's any other ligamentous damage, strengthening exercises, stretching exercises, and if need be, surgery, which would be arthroscopy or insertion of pins into the wrist. Referral and immobilization is a splinter cast for 2 to 6 weeks and referral to an orthosurgeon or physical therapist. This injury can be prevented by avoiding falling on any outstretched hands. My PICOT analysis was that the population was 20 patients with distal radius fractions with evidence of scapholunate dissociation. Observing changes in X-ray and wrist function was the intervention. They compared the function of the wrist as either excellent, good, fair, or poor, and the gaps between the scaphoid and the lunate at the time of the injury, immediately after the closed reduction fracture, at removal of fixation, and 1 year post-injury. The outcome was that the scapholunate dissociation with distal radius fractures is incurable by cast immobilization, and the time was 3.5 years.